Hi, this is Bala. Welcome back to my channel where we provide knowledge on clinical pharmacy with a particular focus on older person care. In this video, I would like to discuss on the pharmacokinetics and also the pharmacodynamic changes that happen in the older person. Pharmacokinetic is one of the basic concepts that is integral for the successful application of pharmaceutical care. It describes the process of drugs being absorbed, distributed, metabolized, and eliminated from the body. All these components have been shown to be affected by the aging process, which affects the therapeutics and also the adverse effect of the medication. Let us now look into the first component of the pharmacokinetic, which is absorption. Once a drug is administered to a person, which is older person in this case, it has to be absorbed into the body through one of the three mechanisms. First is the oral absorption. Second is pre-systemic clearance, or also known as the first pass effect, or transdermal absorption. Oral administration of drugs leads to absorption through the GIT, which occurs primarily through the intestines. There are many factors that can influence the absorption at the site, such as comorbid condition. Example of this comorbid condition can be congestive heart failure, renal failure, or COPD, or age-related physiological changes and concurrent medication such as the antacid, antifungal, proton pump inhibitor, etc. Specific physiochemical properties of the drug, such as the need for an acidic environment, may also affect absorption. Other than that, the rate and extent of the absorption of the drugs are determined by the delivery of the drugs to the small intestines. Several age-related physiological changes may also influence absorption. These changes include a decreased gastric emptying rate, followed by a decrease in intestinal motility, and finally, decreased intestinal blood flow. There is also enough evidence to show that as someone gets older, there will be increase in the atrophy of GI cell. When there is an atrophy in the cell, it's going to cause decrease in the intestinal surface area. There is also evidence showing that as humans get older, there will be decrease in the gastric acid secretion. Whenever there is a decrease in the acid secretion, obviously it's going to increase the gastric pH. And increase in the gastric pH will cause delayed dissolution of certain tablet or drugs. Other than that, it is also being observed that when people get older, there will be decrease in the saliva. Decrease in the saliva will cause reduce in the absorption of sublingual preparations. And finally, the reduced peristalsis happen in the older people, and this will cause delayed emptying rate, as I mentioned previously. The slowing of the transit time into small intestine does not cause much changes in the overall absorption. It's going to take a longer time to maximal concentration, and this will reduce the maximum concentration in the body, and obviously this is going to cause slow onset of action of certain drugs. Certain group of older patients may have achlorhydria with decreased secretion of hydrochloric acid. This most often occurs in individuals with history of peptic ulcer disease and or gastric surgery. Treatment with high doses of proton pump inhibitor and histamine 2 blockers may also contribute to this condition. Patients with achlorhydria may have reduced absorption of vitamin B12, iron, and calcium, which is important in older people. Absorption changes in the elderly, however, rarely cause any clinically significant effect. Overall, the changes in the gastrointestinal or GI absorption in the elderly may influence the rate of absorption without significantly affecting the quantity being absorbed. This is important. In addition, the absorption of carbohydrate and several nutrients, including iron, calcium, and thiamine, are reduced in older person. Systemic clearance is also known as the first pass effect, which happens when drugs are fully absorbed by the GI tract and extracted by the liver at a rapid rate, resulting low systemic concentration. However, a decrease in portal blood flow due to aging may lead to a decrease in the first pass effect, and therefore an increase in systemic bioavailability of the drug. Absorption through the intramuscular route may also be affected in the older person due to a decrease in muscle mass, decrease in peripheral circulation, and increase in the connective tissues. All these changes may possibly affect intramuscular absorption. On the other hand, there is inconclusive data to support the age-related changes of absorption via the transdermal route. Nevertheless, changes in the skin associated with the aging process can also cause a decrease in skin hydration, decrease in surface lipid, decrease in peripheral circulation, and increase in keratinization of the skin, possibly decreasing the absorption from transdermal preparations. Little evidence is available to identify if significant changes occur with absorption of medication from transdermal patches. Changes in the skin associated with aging, such as reduced blood flow and thinner skin, as I mentioned earlier, should not be dismissed as possible enhancer or detractors for drug absorption through the skins. Studies with fentanyl transdermal patches in the older people did not show any statistically significant differences. However, great variability in absorption in all individuals may make such studies difficult to interpret. It is known that elevated body temperature will increase fentanyl absorption. The cooler skin of the elderly may likewise inhibit absorption. Now let us take some time to look into the second component of the pharmacokinetics, which is distribution. Once a medication is absorbed into the body, it will be distributed throughout the body to exert its pharmacological effect. The distribution of drugs can be affected by a variety of factors. Three most important that you have to know is the body composition, plasma protein binding, and organ blood flow. Body composition changes significantly with aging. Thus, in older person, there will be a decrease in lean muscle mass and total body water, but an increase in the percentage of body fat. So you have to remember this. There will be decrease in TBW, which is total body water, decrease in lean body mass. However, there will be increase in the percentage of body fat. The changes of the drug distribution in the older person can be mainly due to the decreased cardiac output, increased body fat, and altered regional blood flow and also tissue barriers. Overall, there will be increase in the volume of distribution of lipid-soluble medication and decrease in the VD of water-soluble medication. Decrease in total body water will actually affect the volume of distribution of water-soluble drugs. Water-soluble medication will have a smaller volume of distribution. Therefore, smaller doses will be required to attain a therapeutic response. Aminoglycoside, vancomycin, and beta blocker are examples of hydrophobic medications which exhibit a smaller volume of distribution in older adults with decreased total body water. Hence, this may cause higher serum concentration, which lead to the possibility of toxic effects among older persons. On the other hand, an increase in the percentage of body fat can cause increase or greater volume of distribution for fat-soluble drugs such as diazepam, lidocaine, and antipsychotic agents, causing prolonged half-life and accumulation of the drug, subsequently leading to adverse drug effect in the elderly. A reduction in the lean body mass can cause a reduced volume of distribution for drugs which distribute into lean muscle mass. One such drug is digoxin, which will have a decrease in VD from an average of 6 to 7 liter per kg in young adults to an average of 3 to 4 liter per kg in geriatric patients. This will lead to an increased drug concentration and can cause digoxin toxicity. Lipophilic medication pose a unique problems in the older patient. With the increase in the percentage of body fat seen with most geriatric patients, one would anticipate that a larger dose of fat-soluble medication would be needed to fill up the large volume of distribution. However, because the clearance of medications is directly related to its volume of distribution, the geriatric patient will not be able to clear fat-soluble medication as quickly as a young patient, and this medication will accumulate, creating an increase for toxic effects. As the volume of distribution increases with the elimination half-life held constant, it will take longer to clear the medication from the body. To avoid this problem, lipophilic medication should be used at reduced doses or increased dosing intervals. Benzodiazepines and antipsychotic medications are examples of medications that are lipophilic but have a higher risk for accumulation in the older patient due to the larger volume of distribution. Other examples are barbiturate, amiodarone, teicoplanin, verapamil, and haloperidol. The protein binding in the older person may or may not be changed. For example, in a healthy older adult may have normal concentration of albumin and alpha-1 acid glycoprotein. Some studies also have shown that as someone gets older, there will be decrease in serum albumin levels and also decrease in the protein affinity. Certain conditions such as malnutrition and also frailty, however, are associated with lower serum protein, particularly albumin. Albumin may also be further reduced in conditions such as heart failure, renal diseases, rheumatoid arthritis, hepatic cirrhosis, and also some malignancy. Basically, most of the chronic diseases can cause reduced albumin level. This obviously may cause decreased drug binding capacity in the older person. Drugs that binds extensively to the albumin level are phenytoin, warfarin, propranolol, diazepam, levothyroxine, digoxin, and furosemide. These are the examples for older person. In acute conditions or malnutrition which result in a sudden decrease in albumin level, the free fraction of highly protein-bound drugs in the body will increase, enhancing the effect of the drugs. Thus, drug interaction may also occur when there are two highly protein-bound drugs such as phenytoin and sodium valproate given together, as sodium valproate can increase in the free fraction of phenytoin by 30 to 100%, resulting in phenytoin toxicity at therapeutic serum concentration. Another example of the drug that is going to be affected due to the changes in the plasma protein level is actually warfarin. Lower doses of warfarin will be required as someone gets older because there will be decrease in the clotting factor synthesis. Warfarin is highly bound to plasma protein albumin. If you remember, it is 99% protein binding capacity. Warfarin has a narrow therapeutic index and a small volume of distribution. Aspirin can displace warfarin from plasma albumin if you are given aspirin and warfarin together. The displacement of 1 to 2% of bound warfarin doubles or triples concentration of free warfarin concentration. This may cause increase in the bleeding tendency. Warfarin binding capacity decreases proportionally with lower plasma albumin level in the older person. I hope by now all of you would be able actually to relate and give some example of the drug that may be affected due to the distribution changes in the older person, which is due to the body composition changes, protein binding capacity changes, and also organ blood flow reduction. The liver is the primary organ responsible for drug metabolism or detoxification. It is responsible for both the synthesis of various protein, substrates, and enzymes, and for converting chemicals from one form to another. In older patients, the physiological changes associated with aging can affect the metabolic capacity of older patients, and there is reduced hepatic blood flow and liver mass, which will significantly affect the metabolism of a drug. The decrease in hepatic blood flow may cause a drug to be introduced to the liver at a much lower rate, and there is thus a higher chance for toxicity as the bioavailability of drugs undergoing extensive first-pass metabolism such as propranolol and labetalol can be significantly increased. Liver mass and intrinsic metabolic activity, which include the cytochrome P450 enzyme system, is also reduced during the aging process. Thus, dosage adjustment in older patients is warranted, and the reduction of dosage is always recommended for those drugs that undergo first-phase hepatic metabolism such as lidocaine, beta blocker, and also narcotic analgesic, although there is no precise formula that is used to calculate the dosage of drugs based on liver function. The liver uses various types of reactions to complete the transformation process. Phase 1 reactions involve oxidation, reduction, or hydrolysis, whereas Phase 2 reactions involve conjugation to produce water-soluble compounds ready for excretion. Cytochrome P450 are often involved in Phase 1 reaction but not in Phase 2 reaction. In older person, Phase 1 reactions are slightly impaired, resulting in slower clearance, higher extraction rates, and higher bioavailability of drugs. The conjugation pathway in Phase 2, which involves glucuronidation, acetylation, and sulfation, are also affected by age-related changes, but to a lesser extent. That is why we always say that phase 2 reaction do not change significantly with age. So we can summarize that in phase 1 activities, for example oxidation and reduction, will be decreased. In phase 2, which is conjugation, it is unchanged. Cytochrome P450 activity is usually unchanged, except they will be reduced in the enzyme activities in a cytochrome P450 in frail elderly. Some of the example of drug that will be affected in the metabolism is tricyclic antidepressant, citalopram, beta blocker, warfarin, phenytoin, propranolol. So far, we have covered three main components of the pharmacokinetic, which is absorption, distribution, and metabolism. Let us now dive into the last one, which is elimination. The removal of drugs from the body happens primarily by excretion through renal elimination. Glomerular filtration and tubular secretion is the example of renal elimination, and other minor pathway of eliminations are feces, breath, sweat, and also saliva. Aging is associated with anatomical and functional changes in the kidney, and the kidneys will decrease in size with renal, tubular, and also vascular changes as someone gets older. Besides, there is also a decrease in the number of glomeruli. These functional changes include a decrease in glomerular filtration rate and mean creatinine clearance rate. Drugs that are more than 60% excreted by the kidneys are affected by a reduction in the kidney function, and the half-life of the drug will be prolonged, causing an increase in serum levels of drugs. Examples of drugs excreted primarily through the kidney include digoxin, ACE inhibitor, diuretics, allopurinol, and others. Hence, a reduction in dosage or adjustment of the dosing interval may be necessary in older patients with decreased renal function. And that is why we can see that one of the table in the BS criteria is drug that should be given in courses where the dose has to be adjusted in patient less than certain ml per minute. Pharmacodynamics refers to the way drugs affect our body. Let us now look into some of the examples of the pharmacodynamic changes that happen in the older person. There is a general trend of increased sensitivity of altered drug response in older adults due to the changes in the number of receptors, changes in the concentration of the drug at the receptor, and post-receptor alterations, changes in the receptor affinity, and finally, age-related impairment of homeostatic mechanisms. Most of the studies on pharmacodynamics changes among older persons focuses on the drugs which act mainly on the cardiovascular and central nervous systems. Some of the changes of the effect observed due to the pharmacodynamic changes will be discussed in this video. Most frequently associated pharmacodynamic changes in the elderly are observed in the cardiovascular system. This could be due to the higher and more frequent use of cardiovascular medications in this population. Beta adrenoreceptor is desensitized with the increasing sympathetic activity due to age, resulting in a decreased effect of beta adrenoreceptor antagonists such as propranolol on heart rate and also stroke volume. Older persons also tend to experience a higher risk of hypotension due to nitroglycerin or orthostatic hypotension while taking prazosin because of a decrease in baroreflex response and also arterial compliance. Increased sensitivity to medications which prolong QT interval then raises the risk for torsades. Evidence shows that among patients taking warfarin, there is a greater level of inhibition in the synthesis of vitamin K dependent clotting factors in the older person as compared to the younger patient. On the other hand, no changes were observed while using other anticoagulants such as heparin being observed. There is also increase in the sensitivity of sodium potassium ATPase, which increase the toxicity to digoxin, especially when the patient is having hypokalemia. The central nervous system is the second most common organ system affected due to aging, where the aging process has been reported to cause multiple changes in neurotransmitter responses. One example is the decreased number of dopaminergic neurons, decreased level of dopamine transporters, and decreased density of several types of dopamine receptor. These changes will lead to an increased sensitivity towards antipsychotics, benzodiazepines, and anticholinergic medications, eventually leading to adverse drug reactions. Higher concentration of psychoactive agent at nerve ending also occur due to the increased permeability of the blood-brain barrier. Other example is the increased risk of tardive dyskinesia and Parkinsonism with antipsychotics. Now that we already know what are the changes happen in the pharmacokinetics and pharmacodynamics in older person, it is important for us to always think these changes whenever we give a medication to an older person. And also whenever we do medication review. We have come to the end of this video. If you enjoyed this video and want to hear from me again, be sure to hit the subscribe button before you go and leave your comments. Thanks for watching.